Hi, Julie. Thank you so much. Hello, everybody, and welcome to this webinar. As Julie mentioned, we'll be doing third and the final webinar in this series talking about pain medications. And today we'll discuss about opioids. Can they be tapered, and why do they need to be tapered? So just to give a background, those who could not attend the previous two sessions, we are talking about pain and the pain medications because the way we understand the pain and the medications is rapidly changing, is becoming more understood and better managed. And because of that, I would recommend, like, whatever information I'm sharing with you today and what I did in last 2 months, research on your own, make sure that it is updated information, and of course work with your healthcare team. Excuse me. I will be using mostly generic names of the medications, but I'll use some brand names to make it more relevant for you guys. And I have no disclosures to make with the companies who manufacture those medications. I also have brought in some images from the internet, which may or may not be acknowledged individually. In this three-part series, in the first webinar, we talked about what is pain medication, and then in the second one, we talked about opioids and opioid addiction. And today we're going to talk about tapering of opioids. Objectives for today would be a brief review of part 1 and 2. Then we'll talk about tapering or DePrescription. How do we do that? What type of tapering? What is it really? And what are the options available for us if it is non-pharmacological pain management or pharmacological pain management, which can replace opioid use. I'll also share a lot of resources with you today, but instead of waiting for the resources towards the end, what I'm going to do is I'm going to give you resources as we go throughout the webinar. And if you don't have pen and paper ready to make the notes, just know that all 3 webinars will be available on christopherreeve.org, their website, as well as the YouTube channel. So webinar 1 and 2, we talked about pain. There are 2 types of pain, nociceptive and neuropathic pain. And also the medicines which work for one kind of pain may not work for the other kind. So there are different mechanisms of action for the medicines depending on the type of pain people are experiencing. We talked about all the risks, benefits of the medications, how to use them, and how to use them safely. The second webinar was mostly about opioids, why opioids are not really recommended for a chronic pain after spinal cord injury in most cases. Because of the side effects, the adverse events, a lot of drug-drug interactions, and the biggest risk is the breathing emergency. People with spinal cord injury may not be able to breathe on their own properly, but if you're adding a risk by overdosing with opioids, which also can reduce the breathing capacity, that can lead to death. Very serious implications here. For people who are already using opioids, and we know it's not recommended, a slow tapering might be considered, and we'll discuss that today. So what is DePrescription or med tapering? So this is kind of a new phenomena. So far, when we start people on a medication, we do not stop, or we do not know how to stop. So DePrescription is a structured approach to reduce or maybe eliminate use of a particular medication to improve health and minimize adverse drug reactions and reducing the pill burden. Algorithms or the protocols have already been developed for DePrescription for certain classes of medications. Right now, I think we have more than 10 classes of drugs where we have the protocols available. Unfortunately for opioids, particularly opioids in spinal cord injury and spinal cord disorders, it's a new emerging area of practice. However, some of the hospitals and some doctors have already created their own protocols. And the goal of med tapering would be safely discontinuing the medication which is no longer needed, no longer serving its purpose, or where the risk is higher than the benefit of the medication. Why we are going to focus today on just the opioid tapering. So why do we want to do that? Because opioids present the risk to quality of life and the life itself. Department of Health and Human Services considered breathing emergencies as an epidemic, which is connected with opioid overdose. In our society, we know, at least in America, we tend to overprescribe medications and overuse all the medications in general. There's a word called polypharmacy. So when people take 4 or 5 or more than that medication, that number of medications in a day, it's called polypharmacy. And we have an additive effect of the side effects. So it's not really a healthy situation when we have to give medications to mitigate the side effect of the original medications. Plus, the chances of drug-drug interactions are also higher. When we include opioids in polypharmacy, the chances of adverse drug reaction or adverse drug events exponentially become higher. The second reason would be the opioids may not be meeting the treatment goals. So in the second webinar, we talked about tolerance and dependence. So if opioid painkiller, particularly at higher doses, higher than 50 MME, which is morphine milligram equivalent, and it is combined with other controlled medications like benzodiazepines, and it not improving the quality of life or not improving the pain management, then there might be signs of opioid use disorder. It's highly recommended we taper the opioids. People might be at risk of OUD. Of course, we talked about breathing emergency and other adverse events. However, some people may not be the candidates for tapering. So we have identified people who are going through cancer treatment, palliative care, end-of-life care, and many of you probably who are listening today may not be good candidates. So that needs to be decided in consultation with your healthcare team. So how do we do the med tapering? The first thing is to educate yourself. So thank you for joining this webinar, listening to this, because this is how we're going to start educating ourselves and then discussing with the healthcare team how do we taper the medications off. One big caution with opioids, please do not abruptly stop taking these medications. Particularly opioids, we have withdrawals. We're going to talk about that in a few minutes. Today we're going to focus on voluntary tapering, so knowingly planning ahead of time, but there could be a forced tapering. So I would recommend talking to the doctor if you are taking opioids right now. So in case of a natural disaster, there's an emergency, there might be a drug shortage in the market, medicine is not available, and that time your body will go into withdrawals. So that we call is forced tapering. So you want to create a plan in case of that emergency. And if you have more questions on it, you can ask me later and we can discuss in detail. So some of the potential factors. So one biggest thing is considering the whole person. So we know the bio, psycho, social, spiritual model where we do not look at just the pain, because the same pain, say knee pain, might not feel like anything to somebody. They might be still running around and doing all the work. And for some people, like little bit pain could be very excruciating. And that could be related to the psychological situation, social and spiritual as well. Looking at the history of your medication. So if somebody has used the opioids for longer time, particularly more than 2 weeks, we need to have a medication withdrawal plan. So definitely discussing that with the healthcare team. So I talked about withdrawal. So if somebody is taking opioids for a while and they suddenly stop taking the medicine, almost immediately people can experience the withdrawal symptoms within 24 hours or so. And those symptoms could be ranging from mild anxiety to agitation, nausea, vomiting, diarrhea. So I'm not going to read the list. You can always go back to the webinar and read through the list. So please talk to your healthcare team right away if you have difficulty with withdrawal, so that they can give you some pharmacological options, and we're going to talk about non-pharmacological interventions today. So for tapering plan, I called it Tapering Plan SOS. So support, owning it, and steady. So first thing you want to do is getting the support. So seeking a healthcare team that has the expertise that is required for tapering off opioids. Then choosing the pharmaceutical and non-pharmaceutical options to support you in this whole journey. We talked about withdrawal, so we want to minimize and stay ahead ahead of the symptoms of withdrawal. The second most important piece is owning it. So if you're motivated, you're willing to learn about it, you're accepting it, you're committing to yourself with persistence, that will help a lot. And the third part is the slow and steady. So right now we don't have guidelines, so what we have seen is many doctors would suggest reducing it by 10% of the original dose per week, or maybe per month, maybe every other month, depending on how long person has been using opioids for. One thing to remember is that if you are tapering your opioid and suddenly for whatever reason you need to increase the dose, do not return to the high dose immediately. It needs to be gradually increased, otherwise it can cause an overdose and a breathing emergency, which can be fatal. So one of the rehab hospitals I visited a couple of years back, they actually assembled an ad hoc pain committee and implemented a patient education and voluntary opioid tapering program, which was very exciting. And what they found within 6 months, people with spinal cord injury who were taking more than 30 milligrams per day of oral morphine equivalent, 56% reduction in number of people just by doing the med management, medical oversight, but doing it voluntarily. They also reduced the polypharmacy. In this case, the polypharmacy was defined as 10 or more medications in a day, but there was a 35% decrease in polypharmacy. So I hope this gets replicated throughout the country, maybe throughout the world, where we can successfully taper people off opioids which are not helping and the risks are higher than the benefits. So here the medical oversight is needed, but the outlook of the person wanting to taper the medicine is very, very important. So let's begin with pharmacological interventions. What can doctors do to help you with this? So I see a lot of questions in the past, and today also I'm seeing, can we talk about CBD? Yes, I'm going to cover CBDs here. So non-opioids, so we're going to go over those quickly. We talked about MAT, Medication-Assisted Treatment Program, in webinar number 2, which you can play anytime you want. We'll discuss cannabis and herbals, nutraceuticals, and vitamins first. This I found was very interesting. It was published in JAMA Network, which is Journal of American Medical Association. What this study concluded in New York was opioids were no better than ibuprofen. So when they gave, in emergency room, gave product with opioid with acetaminophen combination, and they gave some people ibuprofen with acetaminophen after 2 hours of emergency with acute extreme pain, there was no major difference. But just to give you an idea that opioids have been over-marketed, oversold, they may not be as important and functional the way we used to think about them. MAT. So just a review from part 2. Methadone is an agonist. It's a painkiller. It's a very powerful painkiller. The effect can last up to 8 hours. It's better than oxycodone or hydrocodone or other opioids because it blocks the euphoric effect and it mitigates the opioid withdrawal. Buprenorphine is not an agonist. It's a partial agonist. So it helps people when they are withdrawing from opioid use, but also the effect for pain lasts up to 8 hours. So if somebody is taking buprenorphine as a MAT treatment, they might repeat the dose every 24 hours, and I've seen some people getting it every 12 hours. But if you're using it for pain management while you're in recovery from opioid, then you can repeat the dose every 8 hours. Naltrexone will actually block the opioid receptor. So if somebody is taking opioid, naltrexone is not recommended because that will put you into withdrawal immediately. So you want to stop opioids for at least a week and then start naltrexone. But I found a couple of studies very interesting that if people take low dose naltrexone called LDN, so there's promising effect on chronic pain, so 4.5 milligram. So for medication assisted treatment, we use 50 milligram to 100 milligram naltrexone a day. But for pain management, only 4.5 milligram at bedtime has shown to be effective for chronic pain. Cannabis. So this has been really a popular question. I think every webinar I came across this question several times. So there's a lot of controversy, a lot of confusion out there. So I'll try to keep it simple because we don't have a lot of time, but I would welcome more questions if you have any after the webinar. Cannabis is a plant, and within cannabis there are at least two major varieties called cannabis indica and cannabis sativa. And now we have many hybrids also available. Most popular of them are marijuana and hemp plants. Cannabis plant contains more than 50 active substances, active chemicals. We call them cannabinoids. Now, some of the cannabinoids are very well studied and very prevalent, so they're available in high concentration in both these plants. So THC, which is tetrahydrocannabinol, and the second one is CBD, which is cannabidiol. THC is addictive, psychoactive, so that has created a lot of problems for the society. So we'll talk about that in a minute. Cannabidiol, CBD, actually has medical benefits, so we'll discuss that as well. Hemp, which is usually cannabis sativa, contains 0.3% or less of the THC. That's why it is not addictive, it's not dangerous. It is legal to be used in industry. You can see hemp everywhere, and people are extracting CBD oil from hemp as well. On the other hand, marijuana can contain up to 40% of THC, which can cause dependence, tolerance, and it is one of the major gateway drugs. So people start on marijuana and they move on to other substances, other drugs, which have potential for abuse. So the biggest confusion is it legal? So let me try to answer that briefly. So cannabinoids are considered one of the most commonly abused illicit drugs. At federal level, marijuana is Schedule 1 controlled substance. I briefly talked about that in webinar 2. I'm going to repeat that here. So DEA, Drug Enforcement Administration, which is part of Department of Justice in America, they have 5 classes of, or 5 schedules of controlled drugs. Schedule 1 is illegal to possess and use. Schedule 2 have high risk of dependence and addiction, so they are very controlled by the doctors and the pharmacists and the whole industry. Schedule 3, 4, and 5 are also addictive. They can cause dependence and tolerance, but they're not as bad as Schedule 1 drug would be. So marijuana is still illegal at the federal level. So many states have legalized marijuana, and that is causing a lot of confusion. So one case I found was about, I have a raised hand, but I don't see a question. Okay, the question is about CBD, so I'll get back to that. So Mr. Brandon Coates, he lives in Colorado, and he used to work for a call center, and he was using medical marijuana off-duty because of his spinal cord injury-related spasticity and seizures. And he was found positive for marijuana, of course. He got caught between the state and the federal laws. In Colorado, medical marijuana was legalized in year 2000. In 2012, they expanded to use it for recreational use also. However, Mr. Coates lost the case. The Supreme Court ruled in favor of employer, and the reason for that was the supremacy clause, which is part of the U.S. Constitution. It dictates that federal law is the supreme law of the land. What I learned in my pharmacy school was, if there is a conflict between federal law and the state law, you want to follow the law which is more strict. So in this case, the stricter law is the federal law, which says marijuana is Schedule 1, it's illegal to possess and use. So I think this case has created some precedents there, some track record that it's really not safe to use marijuana legally in any state in the country. However, a lot of things are changing right now. In 2018, we had a farm bill which kind of legalized the hemp products and be governed by as an agricultural product instead of a healthcare product, but legally it is still being interpreted. One medication got approved by FDA called Epidiolex. So that is approved only for 2 rare and severe forms of epilepsy. It's found to be helpful for seizures. And it is scheduled as a Schedule 5 drug by the DEA. So it is safer than just using marijuana, which is Schedule 1 drug. The general cautions, as I mentioned, cannabis is a gateway drug. There was a study which followed up with over 33,000 people. What they found was people who use cannabis, their use for non-medical opioid use is much higher, and possibility of them getting addictions or opioid use disorder is also much higher. So we haven't found we don't have data which proves that people who are using cannabis, they have less propensity to get addicted to medications. Online purchases are risky in terms of safety of the medication, reliability, does it even contain CBD or not, what percentage of CBD is in there, and legality, of course, is questionable as well. As a pharmacist, as a healthcare professional, my biggest concern would be the drug-drug interactions. Cannabinoids are metabolized by the liver through a system of enzymes called cytochrome P450 system. Now, many medications are also metabolized by the same system. So, CBD is a potent competitive inhibitor of that enzyme. Actually, many of those enzymes. So, many of the medications you might be taking right now, those doses need to be adjusted. For example, if somebody is taking warfarin, which is a blood thinner, and they start to use marijuana or CBD, they will have to adjust their warfarin dose downwards. Otherwise, person can start bleeding. High risk. All right, we're going to switch gears, talk about other nutraceuticals, herbs, and vitamins here. So we don't have enough time to go over all the products, but white willow bark, which is very, very similar to aspirin. Aspirin is standardized, so I will not recommend that, but it is found to be effective for lower back pain and osteoarthritis. Devil's clawroot is popular in Europe, for musculoskeletal pain. We have curcumin, which is an active compound found in turmeric and ginger. It's an anti-inflammatory as well as antioxidant, so it can help with pain. Glucosamine, chondroitin, and MSM are being used for osteoarthritis, for any kind of joint pain actually. Be careful with glucosamine, can impact your insulin level if you have diabetes. CoQ10, coenzyme Q10, has been found to be effective for muscle pain and weakness, which is caused by statin drugs. Statins are used for hypercholesterolemia, so somebody has high cholesterol. Then we have Chinese poppy plant, which works with the opioid receptors. Herbs and vitamins. So we have some evidence for capsaicin. Capsaicin is an active ingredient from chili pepper. So we have creams, lotion, ointments, films, gels. So all those products have mild effect on musculoskeletal, but also the neuropathic pain, which is kind of exciting. You don't have to take anything by mouth. You can just topically apply it. Particularly the area affected by pain is much smaller. Linseed oil, chamomile extract. Magnesium is also very common. So magnesium we have found effective for headaches, for migraines, but also for musculoskeletal pain or neuropathic pain. So if somebody has deficiency of magnesium, I would definitely discuss with the doctor, start that supplementation, keep it safe, but it could be a very low cost intervention to reduce the pain level. Two vitamins, vitamin B and D. So deficiency of vitamin B, particularly B12, can cause neuropathic pain, and deficiency of vitamin D can cause bone disorders, so joint pain and musculoskeletal pain. So it's easy blood work. You can get the levels of vitamin B and D tested, and if you have low levels, you can take an over-the-counter or prescription supplement. Colocynth and kratom are not recommended. Colocynth was banned by FDA, but they're still out there in publications and in the market. Kratom has become very controversial. FDA recently reported that 44 people died because of kratom use. So at the moment, what we know is not recommended. Any of the herbal products, nutraceuticals, and vitamins, they're not standardized or FDA approved. Because of that, they don't follow the same standards what we have for the pharmaceuticals. So they could be adulterated, they could be toxic, there might be drug interactions, there might be efficacy issue, how are they produced, in what kind of conditions. We don't really have much data on that. There are two organizations, USP and NSF, so United States Pharmacopoeia. They are international seals for over-the-counter herbal or nutraceutical products. They randomly test, so they do not guarantee that product is therapeutically effective, but their seal is a good indication that the product contains the amount of ingredient. So if it is saying it has vitamin D, it will make sure that it contains vitamin D and also is not contaminated with other dangerous substances. So definitely, please, if you're taking any medication, including over-the-counter products and herbs and nutraceuticals, please check with your pharmacist. Let them know you're taking those so they can check for potential interactions. We do not have data for everything, but at least in case of CBD and marijuana, we know how it is metabolized and how it will potentially interact with your existing or future medications. Checking with your healthcare team, letting your caregivers, everybody know what you take. One more caution here is if you are going to go for an interventional procedure or a surgery, American Society of Anesthesiologists recommends that you stop taking your herbal products at least 2 weeks before the surgery or the intervention. So those products might be interacting with the blood thinner and might make the blood thinner. It will be hard to recover from the surgery, so please remember that. Consumerlab.com and abc.herbalgram.org, these are the two websites as a resource I would recommend if you want to study up and get more information about the herbals and nutraceuticals. So I don't know everything if they're saying. I may or may not agree with what they have, but at least it'll give you some idea when you're researching more about a particular herb or a nutraceutical. Let's switch gears to non-pharmacological interventions. So whatever you are going to put through the mouth, we just talked about. So what can you do on your own without having to pop a pill? That's what we're going to talk about. So there are a lot of interventions available. Many of them are already listed on christopherreeve.org website in the pain management section. So we're going to very quickly go over all these interventions. We don't have enough time to go over each one of them in detail, so I'll do my best, and of course I would welcome more questions and your own research before you start using these modalities. So one of the first things I would recommend is the wheelchair. If you're using wheelchair, adjust the wheelchair instead of you adjusting to the wheelchair. So adapt the wheelchair so it fits your body, it fits your lifestyle, it is optimized for your use at home as well as the work environment. That way you will conserve the energy and not create extra burden on your shoulders and the arms and other parts of the body. The non-pharmacological options which I had listed in the previous slide, they are listed alphabetical, so this is how I'm going to go over this list alphabetically, not on the basis of their level of evidence, how effective they are. Okay, so first one is the activity. So some people tend to isolate themselves when they have chronic pain. Any activity which a person will enjoy, whether it is a physical activity or a non-physical activity. It could be a social activity or a solo activity. So please put that on your schedule. Make yourself a priority and do that activity. Whether you want to play cards or you want to build Legos or any models, any activity which you enjoy, put that on your schedule and do it on a regular basis. If it is a physical activity, make sure you pace yourself, so doing it safely, slow, and steady, and taking breaks if you feel tired. Acupuncture is part of ancient Chinese medicine in which the acupuncturist, some people call them punks, they will insert some very, very thin needles. The needles are so thin, they're much thinner than the sewing needles. They will put it at specific points, or the meridian points on the skin, which helps in reducing the pain. So there are a lot of studies out there, and actually there are two kinds of acupuncture. The traditional acupuncture is found to be more effective for musculoskeletal pain, and electroacupuncture has been found to be effective for neuropathic pain. There's a website called acufinder.com. You can put your zip code in acufinder.com. It'll give you a bunch of options for local acupuncturists. And now many insurance companies actually have started to pay for acupuncture as well. We have another organization called POCA, People's Organization of Community Acupuncture. So if somebody doesn't have insurance or insurance is charging a very high copay, in that case, POCA actually makes it very affordable and accessible for a lot of people. So if you go to their website, pocacoop.com, you'll find clinics who will treat you on a sliding scale basis according to your income level. Adaptive exercises. So adaptive exercises can be done on the land or can be done in water. So both have their own advantages and disadvantages. And studies have shown that most exercises would actually reduce the pain perception, intensity and average pain scores, and average depression scores. They also help in improving the positive mood states and improving the quality of sleep. Some of the resources, first thing I would recommend is checking with your doctor, physical therapist, or occupational therapist to find the right class. Right intervention is very, very important. We talked about the right wheelchair, so making sure you have the right wheelchair and the gear for the activity you want to you choose for yourself. There are a lot of adaptive sports teams out there in every state. I think they are there. Therapeutic recreation programs are out there. There's an emerging trend of rehab gyms, which are getting very popular. And you can do some classes in person, one-on-one with people. There are some resources online on the YouTube or the DVDs. But I personally would recommend working with your OTs and PTs first, working one-on-one with individuals, and maybe then doing groups before you start using online resources. Yoga. So personally, I love yoga, and I strongly recommend. I teach adaptive and therapeutic yoga. So regular yoga classes may not be recommended for people who have limitations or who have spinal cord injuries. But therapeutic yoga and adaptive yoga have been found very effective. So what is yoga? So yoga involves some gentle movements, some breathing exercises. It has techniques which help you learn how to relax, not just relaxing the whole body, but different parts of the body and different parts of the brain. There are exercises which help with focus, improving the focus, and all these techniques lead towards mindfulness and also meditation. The biggest part is yoga helps empower us to self-regulate. So chronic pain creates a different kind of pain pathway in the brain, and that self-regulation, a self-practice, a regular practice can actually modify, can change that pain pathway. So I call them yoga capsules. So if you pick one or two practices in yoga, whether they're movement, breathing, relaxation, meditation, whatever you pick, whatever you like to do, that short practice, doing it on a regular basis, like taking a yoga pill, will help you creating new neuronal pathways and reduce the pain level. Reading a comment here, there's big sounds in the background. I don't have any sounds in my room. It is very quiet. So maybe Julie or Christina, can you see if there's any background sound pollution there? We have a comment here from one of the audience. I'm going to continue with the yoga part. So we also know that chronic stress, depression, untreated anxiety, and just worrying about the pain intensifies the pain. And yoga helps in reducing the pain. It helps in reducing the stress level. It helps in reducing the anxiety and insomnia as well. So it's not just about reducing the chronic pain with therapeutic yoga. We are talking about reducing other side effects of chronic pain itself. There are many research studies, meta-analyses suggest yoga is a useful complementary approach for not just the pain but also associated disabilities. It has been found to improve the functioning and greater decrease in fear of movement. Yogic breathing has been found to optimize and reduce the chronic pain. It also changes the breathing pattern. So when people have chronic pain, they might breathe very shallow. The breathing might be irregular and it might be strained. So if you train your breathing to optimum breathing, it will help reducing the pain level as well. Slow yogic breathing has been found to be reducing pain intensity, unpleasantness. Many mindfulness and meditation techniques that have been researched to reduce the pain by 57%, pain intensity ratings reduced by 40%. I recently attended a conference and they found like what is really most effective out of all the non-pharmacological interventions, and most people and the researchers recommended meditation would be the one, and therapeutic yoga. So seated therapeutic yoga classes, again, I would recommend doing in person. So the person who is teaching you sees your limitations and can help you guide and adapt the class for you. But there are online resources available as well. There are relaxation and meditation courses are available out there, and there are tons of apps. So I'm not able to recommend a particular app because I've not gone through all of them. But initial stages, I will definitely recommend going to iayt.org, which is International Association for Yoga Therapists. So you can find a certified yoga therapist anywhere in the world, and hopefully in your neighborhood, who can help you find a good yoga therapist. Art-based therapies, so color, dance, music, sound, whatever you like, whatever gives you some enjoyment, will help you divert your attention towards the pain and will give you various degrees of pain relief and modulation. So if you can join some local classes where you can do some art-based therapies, that will be also one of the ways you can reduce your pain medication, hopefully. Auricular acupressure, so this is not acupuncture, it is putting the pressure on the right points in the body. Auricular means in the ear. So what they have found is that in 12 studies, if you put the pressure on your ears in the right spots, it helps in managing the pain. And it's self-management. It's a very easy and cost-effective way of managing pain. Biofeedback. So biofeedback is a technique in which your body gives you the feedback through an instrument so you know what is working for you and what is not working for you. So for example, if you're doing a practice, it helps in reducing the pain. You can actually see it. So there are a lot of machines available out there. EMG, which is electromyographic biofeedback, has been found to be valuable for musculoskeletal pain, particularly the shoulder pain, and EEG, which is electroencephalography neurofeedback, has been found to be effective for neuropathic pain, both immediately and also the long-term reduction of pain. So if you want to look for a biofeedback practitioner, you can go to aapb.org. Biofield technology, so this is like energy medicine, so healing touch, therapeutic touch, or Reiki, they work with the energy of the body and they help reduce or manage pain better. So you can find healing touch practitioners at htpractitioner.com, and for Reiki you can go to reikiassociation.com. Botulinum toxin injections, also known as Botox. So Botox is very popular. A lot of people have heard that word, but it is a toxin. It has been found to be effective for relieving musculoskeletal pain, and in some cases it has been found to be effective for neuropathic pain as well. It has a lot of side effects, so you can go through this list. There are no long-term studies as far as I know at the moment, but show that outcomes for the long-term benefits as well as the side effects. So there are some reports of death, unapproved use in spasticity for children. So this definitely you will have to discuss with your healthcare provider if you want to explore this modality. Diet. So there are certain kinds of foods which can increase your pain or reduce your pain. So you might have heard about anti-inflammatory diet. So there are some food items like ginger, turmeric, chili peppers. They actually help reducing the inflammation. Nicotine, when you smoke, it kind of tricks the body into feeling good. So you might feel the pain is going down, but actually because it reduces the blood flow, it reduces the oxygen available to the body, it can increase the pain level. So just observing what you're eating, is it increasing your pain or decreasing? Becoming mindful of that might help you manage your pain better and reducing the prescription burden. Electrotherapy. So there are a lot of devices out there. Is an emerging option. So some devices need to be implanted inside the body, and some can be used. They're less invasive. They can be used outside the body. So there's a list out here: TDD, CS, DBS, MCS, SCS. So please study them up and find a local practitioner who can help you understand those devices. They might be covered by your insurance as well. And but before you start using them, of course, get all the benefits and risks information as well. The next is heat and cold. So depending on the pain level, they might be helpful for musculoskeletal pain as well as neuropathic pain. One big caution is please do not sleep with a heat patch or a cold pack because they have been known to cause burns. If you sleep with a heat patch, it can cause burn, and if you have a cold pack, it can cause frostbite injuries. Hypnosis and self-hypnosis. So we know pain is all in our head. The part of the body which is injured is sending the pain signal into the brain. And hypnosis can modify that because you're kind of creating an altered state of consciousness. So in altered state of consciousness, the perception of the pain is reduced. Self-hypnosis I find is very empowering. So if you can learn how to do self-hypnosis, that will be really good. It helps in reducing the pain intensity, average daily pain, and results might be short-term, but you can repeat that as often as you want because you're not dependent on other people. If you're looking for a professional, you can go to a hypnotist, but I would recommend find a health professional who also knows how to do hypnotherapy because they might understand your health condition better. So if you go to psychology.today.com, you can just put your zip code and you can find local practitioners. Laser therapy. So we know if you use high power laser, it can cut or destroy the tissues. We are talking about low level laser therapy, LLT, that has been found to be effective on the surface of the body, effective modality for reducing the pain in adults with musculoskeletal disorders, not for neuropathic pain, but just for the nociceptive pain. Magnet therapy. So there are a lot of studies out there, but out of one of the meta-analyses, out of 29 studies, they found only 4 reduced the pain, which is good. The 4 studies reducing the pain level. The problem was there was inconsistency in magnet strength and the placement. What part of the body do we put the magnet in? And definitely the caution would be if you have any pacemaker or any implant with metal and some of the medication, you definitely want to check out with your healthcare team, including the person who is going to do the magnet therapy, to make sure that it is safe. Massage therapy. So massage has been found to be effective for both musculoskeletal as well as neuropathic pain. There are a lot of techniques out there. In Ayurveda, which is an Indian system medicine, they use different kinds of oils which are potentiated by use of herbs. So they help in reducing the inflammation and relax those muscles and improve the pain management. So there are 3 meta-analyses. They found they're effective for shoulder pain, for cancer pain, particularly pain after the surgery. One of the studies found that foot reflexology, that means massaging some specific points in the feet, could be more effective than getting a full body massage. For spinal cord injury-related pain, it helps in increasing the range of motion, muscle strength, while decreasing the pain, anxiety, depression, and fatigue. So website, the resource would be massagetherapy.com if you're looking for a certified or licensed therapist. Mental health support. So what we have found is people with spinal cord injury, up to 50% people could be suffering from major depressive disorder as well. And when we have depression, that can potentiate the pain level as well. So there are two therapies which are recommended. A psychotherapist or a behavioral health specialist will recommend you the right therapy. One is called CBT-CP, which is cognitive behavioral therapy for chronic pain, and the other one is ACT, which is acceptance and commitment therapy for pain. Mental health support, there are a lot of online groups, there are local groups available, there are Facebook groups available, but definitely Christopher and Dana Reeve Foundation has a lot of resources on their website through regular webinars like this one we are doing right now. There are online forums, there are blogs, peer mentors, so please check out those resources as well. And if you're looking for a behavioral health professional or psychotherapist, you can go to psychologytoday.com. Osteopathic manipulation has been found to be effective in neuropathic pain. It might help with nociceptive pain as well, but I found this study, which was very, very interesting. It was a randomized clinical trial. When people were given pregabalin, which is a generic name for Lyrica, they found when we did the osteopathic manipulation in combination with the medicine, the overall effect was much better than either of the treatments alone. So osteopathic manipulation might help, Lyrica might help, but when you do it together, it was more effective for neuropathic pain perception. Then next would be physical rehab. So we hopefully everybody listening to this webinar knows that physical therapists and occupational therapists, they know the most about managing pain. They can give you a lot of skills and strategies to improve the quality of your life, improving the activities. So definitely please, if you have not already done it, checking with the physical therapist. There was a recent study from last year which said that earlier a person sees a physical therapist, it results in reduced risk of opioid use. So earlier people see physical therapist, reduced risk of opioid use for patients with knee pain, shoulder, neck, and lower back pain. Some of the insurance might ask for a referral from a doctor, and some may not, so you may want to check that out as well. Sleep. So we as human beings are designed to be sleeping 1/3 of our life. And we know when people have chronic pain, it will disturb the sleep quality. People may not get into the REM sleep for a long time. And if you have sleep difficulties, that might also make the chronic pain worse. So there's that relationship between the pain severity and the sleep quality, as well as depression and anxiety. So what I have seen and what I personally recommend is learning the art of relaxing yourself. So more you can learn to relax yourself, not just the mind relaxation, but also different parts of the body relaxation, that makes the quality of sleep improve. Cognitive behavioral therapy for insomnia, called CBTI, is considered first-line therapy, much ahead of any of the medications we have. So sleep medications might not be a very good option for insomnia for anybody, but particularly people who are already using other controlled substances. There are a lot of relaxation music available, so pick music which you like to use. There are some apps available, there are CDs available, there are music you can download. Somebody just put a question about melatonin. So melatonin is good, but melatonin is automatically produced in our brain by the pineal gland. So some people keep taking melatonin, think it is working for them, or it may not be working for them, but melatonin works only if there is a deficiency of melatonin or it is not being produced at the right time. So long-term melatonin supplementation may not be a really good idea for everybody unless it's really helping someone. Surgery. So there are surgeries like rhizotomy or cordotomy which can be done to selectively remove those nerve roots or the bundle of nerves which are causing the pain sensation. Since the root cause of the pain cannot be eliminated, we can remove some of the nerves. Of course, that will be a serious procedure, but you might have heard about carpal tunnel syndrome, rotator cuff surgeries, which is good for musculoskeletal pain, and visceral pain, for example, gallbladder surgery or appendix removal, that is more for the visceral pain. So surgeries might be helpful. They just asked me a question, melatonin, what organ is called pineal gland, Pineal, which is situated in the middle of the brain. Virtual reality, so this is high tech, it's a new modality, seems very, very exciting. It is a computer generated experience which is also very interactive, and it takes place in a simulated environment. So you could be seated on a chair and put this gadget on in front of your eyes, and you could be traveling in different environments. And it incorporates listening and visual feedback as well. There are many different kinds of gadgets available out there. We don't have a lot of data yet, but one of the reviews, which was recently published, indicates that virtual reality therapy could help with spinal cord injury associated neuropathic pain. So Reef Foundation's mission is today's care and tomorrow's cure. So we want to care for people who are dealing with spinal cord injuries, also the caregivers, and eventually, hopefully, finding a cure for this serious medical condition. So please feel free to call Reef Foundation. The phone number is on the website, christopherreeve.org. And you can get fact sheets about the pain, many of the topics I talked about today. You can get more information on their website. I would recommend asking about the peer mentor program. So people who have already gone through a situation like yours, they can help you navigate spinal cord injury better. And if you already have experience, you possibly can become a peer mentor as well. You can also become an advocate for people who are dealing with spinal cord injuries. If you are yourself had spinal cord injury, or you're a caregiver or a health professional. If you want to report on, you want to give your recommendations for the pain management best practices, we have until April 1st, 2019. You can go to HHS website, which is Health and Human Services, and submit your comments about the best practices for pain management. I'm going to give you just a summary checklist for all the 3 webinars together here. First one is knowing your physician and knowing your pharmacist. Please share with them all the medications you take, including over-the-counter medications. Also let them know if you're using any non-pharmacological interventions so that they can help you find the drug-drug interactions or that drug intervention interaction as well. Drug intervention interaction. I just wanted to make sure I spoke it right. If you have new pain or your pain becomes intensified, please do speak to the doctor. Know your medications. So some people take a lot of medications. Unfortunately, they don't even care to spell the name of the medication or pronounce the name of the medication. I would strongly recommend please learn about the medicines you take, what is good about them and what is not so good about them. Staying updated on the medicine. So one of the resources I recommended was knowyourmeds.com. So it's a free app. When you don't have to put your full information into it, but you can enter all your medication names. So if there's a new warning from FDA or WHO or any updates on the medication, it will give you detailed information about that particular medicine. It also can help you remember taking medicines on time. Some medications you need to take every day at the same time, so it'll give you a pop-up on your phone that it's time to take so-and-so medication. Next recommendation is that you take your medications as they're prescribed for you. So if you're not able to take as they're prescribed, please let your doctor know so they can modify your prescription accordingly. Storing your medicines properly is very important, but if you're not using the medicine anymore, please dispose them off carefully as well. We do not recommend flushing them in the water because these drugs are not showing up in our drinking water throughout the country. If opioids are part of your treatment, please do not stop taking them suddenly. Talking to your doctor, remember the tapering SOS we talked about, finding what will support you with the pain management, owning the whole process, and doing it slow and steady in collaboration with your healthcare team to slowly taper off the opioids, and you might need to add some non-opioid painkillers as well. Understand the signs of breathing emergency and overdose. We covered that in webinar number 2. That can be fatal. Using naloxone in case you know somebody who has overdosed. So having that emergency plan in place is very important. And also developing a plan with your doctor in case of natural disaster where you do not have access to your regular opioid pain medication and you might get into withdrawals. Next recommendation is do not mix your pain medications with alcohol, sleeping pills, or street drugs. All these medications and alcohol go through the liver, and there's a strong possibility of interactions and some lethal, fatal interactions between your pain medications and those medications, over-the-counter or street drugs. Researching non-pharmacological options, so I went through very quick, so I apologize because of the time. I went through each option very quickly, but please research them and see how can you use them to improve the quality of your life and also deprescribing these medications. Consider becoming a ReFoundation advocate and peer mentor. So we have a few minutes for question and answer. I see a bunch of questions here, so I'm going to take those questions. I really thank you all for being on the seminar and listening to all three. Those who missed some parts of it or you were not able to catch the links or the resources, you can always go back in the next few days. They will all be published on ReFoundation website. The first two are already available. And I thank you all for attending these webinars. So first question is, could you please talk about CBD? How do you know what product and how much? So I already covered that. So I believe that question came much earlier. Does smoking marijuana cause the same amount of lung cancer as smoking cigarettes? Great question, but I don't think we have data on that. Anything you're smoking going into the lungs, which lungs are not used to receive, is going to cause some problem. But specific to cancer, I don't think we have any data. Somebody talking about the sound pollution, we already covered that. I think it was just one person's phone. It was not everybody else. What is the difference between osteopathic manipulation and chiropractic? So chiropractors mostly specialized in the spine area. So they do the spinal manipulations, which can have very profound effect, but I excluded those chiropractic manipulations in this webinar because we are focusing more on people with spinal cord injuries. And osteopathic manipulations are done by DOs. They are equivalent to medical doctors, so they're doctors of osteopathy. Their copays, if you're visiting a DO, your copays and the fee almost are same as visiting a regular medical doctor. And they're also covered vastly by all the insurance companies, which is not true for chiropractors. So we are right at 1 o'clock. The next question about the art therapies and electrotherapies, the evidence base. So if you go to the websites I recommended, I think you will probably be able to find more information. Right now it was just a big overview, but yes, there is some evidence for electrotherapies and art therapies for pain management. So thank you very much for all your questions. These will be published on ReFoundation website as well as on YouTube. If you have more questions, please post your questions there. I would love to go back and answer your questions. Thank you very much, everybody.
This concludes today's call. Thank you for your participation. You may now disconnect.